Good afternoon, everybody, and welcome to the first official Grand Round session of the Department of Psychiatry for this academic year. I am Sephora Rosenberg. I'm the Associate Chair for Education, and I, along with a Grand Rounds committee, have put together this series for you that will run every Wednesday from now until forever. No, I'm just kidding. From now until the end of May. But we're very excited to kick off the season this year. I do want to orient you a little bit to the kind of session that you're in now and how to sort of recognize which sorts of sessions are happening when before introducing our speaker for today. So for our department, the first and third Wednesdays are our Grand Round sessions. These are often scholars, expert clinicians, researchers, policymakers, people who have national and international notoriety, who are coming to share their expertise with us. On occasion, we have other people rotating in as well, but all with an eye toward really expanding our knowledge base, our skill set, and our collective conversation. On the second Wednesday of the month are our Romano rounds. Those are typically clinically focused rounds that are hosted by divisions one at a time. And Dr. DiGiovanni coordinates those rounds. I believe next week, we're actually going to hear from Child Division. So over the course of the year, you'll hear from all of our divisions, but that's a space where we will share clinical and educational innovations that are typically population or division focused. And then the fourth rounds of the month on Wednesdays is our Engel rounds. These are often earlier career researchers, both from within the institution and elsewhere. Those sessions and the schedule are coordinated by Dr. Silverstein. And then we also have DICE rounds that are typically occurring on the fifth Wednesdays of the month that have fifth Wednesdays, with a special session for Martin Luther King week in January. We will also let you know when you're coming up on a special rounds in which we're sharing that space with the Department of Neurology. We have 3 sessions over the course of this year that reflect that partnership that we're very excited about. The first one I think is going to be coming up in November, but we will advertise it as such just so that you know, and it will help to explain why you have unfamiliar but friendly faces in the audience next to you from the Department of Neurology. Without further ado, I would love to introduce our speaker for today. He probably is familiar to most, if not all of you, and if not, that's cool. He will be in short order. It's Dr. Ben Lee, who is the John Romano Professor and Chair of our department, who's going to be sharing with us his reflections on the department and where we are and where we're headed in this inaugural Grand Round session. Dr. Lee?
Can you hear me okay? Yeah. Maybe I should, because my microphone is...
This is legitimately the coolest thing ever, that the podium does this.
It's not that I'm tall, but I want to speak a little bit closer to the microphone so that you can understand me better. So, psychiatry with permeable boundary was actually the title of my talk when I first got here at University of Rochester. But I also titled it as a Redux or Reversal. I've been having some doubts actually about, is this the right phrase for our department? This is a phrase that John Romano used in 1947. And with an idea that at that time when I was arriving at University of Rochester, our department was relatively isolated. It was very much, we didn't do much with other departments or the overall medical center. And the idea that I was having was that, can we develop more bridge across the specialties, disciplines? And also there was a lot of division between research and clinicians, and can we also do that, was the idea behind this model of psychiatry with permeable boundary. But now 6 years later, and I'm going into the 7th year, is this the right phrase? It's basically what I was wanting to talk about until, a fire that happened yesterday, right? I mean, trying to advance this. Okay, good. So I was preparing this talk around 10:30 last Saturday, and I get a call all of a sudden from Patrick. Patrick said, "Your chief administrative officer." It sort of tells you, this is a story of my tenure at University of Rochester. Nothing really goes as planned. COVID happens, a lot of things happened. And last Saturday, it was the fire that happened. So we had fire. Our geriatric psychiatry unit, by now, pretty much everybody knows, is closed, and it's going to be closed for the next 4 weeks or so, maybe 3 weeks, 4 weeks. It was not a small fire. The bed and mattress were completely burned. It actually melted the frame. It was enough of fire that it looks like it might have even triggered the extinguisher, the sprinkler system downstairs. And additionally flooded 290-200. Sorry, it's 290-200, not 390-200. So, 290-200 was flooded, 390-200 was completely flooded. And around that time, I was contacted because all of a sudden, we had to evacuate everybody. Okay? So, that some of the pictures are related to some of the how wet everything was. And then all of a sudden, we had to move 11 geriatric patients to the next door 39000. And then 290-200, 21 patients, all of them temporarily to our G90-200, the MIPS unit. But in 30 minutes or so, but it was really rapid. Everything, by the time I got there, by 11 o'clock, actually, I saw most of the leadership was already there, setting up the clinical command center, and then they were already working. The DPS were amazing, actually, in terms of how quickly they addressed it and organized some of these movements and support. And the support staff, the nursing staff was also amazing in terms of, think about how you wanna, in the middle of the night, trying to move 40, 50 patients, all organizing, as well as assigning the beds. It's an incredible Herculean effort. So 10 geriatric patients went to 49000. So 49000, many of you know that it's a pediatric unit, but luckily we had a low census on that night. So we were able to divide up the pediatric unit into two. So west side, we put geriatric patient. East side, we confined, we used it as a pediatric unit. And then the patient who started the fire was moved to the 39000. And then we also moved a couple of patients to the MIPS. And then we moved 18 patients to the CPAP, out of all places. Okay. Now, that was only possible, we were very lucky. It was only possible because CPAP for once had a low census. Okay. Now, essentially, when you do all that, our entire service line related to acute care was paralyzed. 290-200, 390-200, both of them flooded and not operational. ECT suite was also shut down as well. And there was an extensive water damage. And I was walking around and, I was hurt. And that's probably the best word to describe it. I guess you know how much you care when you actually lose it. And I was walking around seeing the ceiling that was damaged and the water that seeped into every corner of 39000 and 390-200, and a lot of them is to 290-200. I was really hurt is the right word to describe it. And this is the these are the units that I've been wanting to renovate and ask for new space and all that capital plan that I've been advocating for. But when it comes down to it, these are the places that we care for our patients, and they were no longer operating. And that was the realization that I had to come to. CPAP, we had to put on temporary diversion because we couldn't admit any patients. It was already filled with 18 acute inpatients. So we worked with the state to divert all the psychiatric patients to elsewhere, meaning Rochester Regional. And essentially, the mental health system in overall Rochester region was very much paralyzed, is probably the right word to describe it. And 49000 child unit was also completely shut down because it was completely full as well. And 39000 was also full as well because it was operating normally, but obviously had no beds now. And that was what we were working on at that time. But nevertheless, as I was thinking about it, nevertheless, we were working on this. And it was pretty amazing how people were able to work together. In the middle of this, around 3 o'clock or so in the morning, I was driving back home and I had this flashback that I remember this. And my flashback was actually something personal. This was about actually around 4 or 5 years after my family immigrated to United States in Seattle. The apartment that my 5 of us were living, it's a 2-bedroom apartment in Seattle, caught a fire. And it also happened around, late at night. And, we were woken up by firemen and we were told to grab whatever that we can. And I don't remember what I grabbed. I think I grabbed my Walkman out of all things. And I think my mom and dad grabbed some of the deeds and whatever. I mean, we were rushed out of it. And 2 days later, we were, the Red Cross came, took us to a motel nearby. That's where we stayed for about a week. And then a couple of days later, we were able to go back and pick up our stuff. And it was sort of like how the 39200 looked like, everything on the water, lots of, smell and everything. And but the most painful thing at the time was the helplessness, the look of helplessness of my parents at the time. Like from their perspective, they came all the way to the United States. They're trying to make a new living. And they felt that they almost lost everything. And then that familiar feeling of anger and sadness is initially what I had when I was looking at those 29200 and 39200 on that particular Sunday morning at that time. But it was different this time. It was very different. It's one thing that I was reminded. My drive to my home at 3 a.m. that evening was not a feeling of helplessness or disappointment or whatever. I almost felt sort of a sense of exhilaration. I was talking to Michael Sharp around that time, I think next day, and he thought I was crazy actually, feeling that way. But I had this feeling that we've done this before. We've done this before during the COVID, during the Daniel Prude incident, all the things that we've gone through. There was no time that we demonstrated the values of our department: communication, collaboration, complementarity, competence, and most of all, compassion during these times of crisis. We really worked together by next Sunday morning, our clinical leadership were rounding, a lot of cleanup. I can't say enough thank you to environmental service workers who came in and got our 290-200 ready. Otherwise, our patients would be still stuck in CPAP for more days. And I actually thought my estimation was at least 2 weeks. But clearly, 290-200 is already open. A lot of repair, quick drying up and cleaning. There's an amazing effort to coordinate and clean up and get that ready. And we'll get 390-200 ready as well. It'll take some time. It'll take some demolition. But by Monday afternoon, 18 patients were back in 290-200. And by Tuesday morning, our CPAP was back on service. And right now, essentially, most of it is in normal operation, except 390-200 that's shut down for the next 3 to 4 weeks. 49000, for the first time in our career, there's a term that I'm creating, pediatric unit. There's a divider between the geriatric side and the pediatric side. And that's how we're going to operate for the next few weeks. We'll see what happens, And CPAP now is fully operational. I think, what I want to talk about is every crisis is an opportunity to learn something and do something different. And it also affords us to re-examine ourselves, and especially the state of department in terms of where we are. One question that I have is that, the wonderful teamwork that our department demonstrated during this weekend, does it have to happen only during the time of crisis? And is there a way to carry those values during the time of peace as well? And I think that's what we want to ask. And we want to do that by asking where we are, and who we serve, which is the most important of all, and our values and mission. And we need to reset and change the course if necessary, and it is necessary. One thing throughout my career that I operated on, throughout my career, I have never been afraid of failures. What's the worst thing that can happen? But one thing that I have always been afraid is regrets, not having done my best. And that's the same attitude that I have about the next year. Our state of department, by and large, is, the same story. Our clinical service is continuing to expand very rapidly. Our research is not the same story, actually, having an unprecedented banner year I talk about. And our community work is increasing engagement at all levels and support. There's a lot of things that we are working on. But education is an area that we do need to re-examine our overall learning environment, and recent special review on our psychiatry residency is a reminder of the gaps. And I wonder, if through the relentless expansion that we have done over the past several years, have we compartmentalized to the degree that we have left gaps in our missions? Remember when you presented this talk, this is September 5th of 2018, we did this 3 main structural changes in our department very rapidly at that time. A lot of people criticized it. A lot of people were questioning this is the right way. We did, warp speed, administrative changes, academic promotion changes. Main thing that we did was the divisional structure. It was essentially aimed for growth and expansion in each area. Essentially, the idea was relatively straightforward. With the wonderful leaders, wonderful programs in 5 different areas, let's give them more independence. and really give them more resources to be able to really expand and provide more services to the growing needs of our community. And this is where we started. And many of the leaders who are on the list are here. Some of them have retired, and this is where we are. We have certainly done what we have aimed to do, and certainly continue to expand, and we will expand to addiction psychiatry 7th division, and we'll continue to forge ahead. We talk about how rapidly our faculty have grown. I think we have gained another 25 faculty members in the last couple of years. That also leads into challenges related to how do we provide more support and provide more mentorship and guidance? Because many of the faculty members are transitioning very quickly from residency or fellowship to the faculty level, and that's not an easy transition. And that's a transition that has to be carefully resourced and paid attention to. Clinical revenue is also getting higher and higher. I think last year we hit the 100 million mark in relation to our overall clinical revenue. And in fact, we probably did a little better because we had to come up with $5 million enhancement to our budget. And we did that as well. So we're moving very quickly. We are a large department that is also increasing our total ambulatory care volume very rapidly as well. And it's quite amazing. Now we are hitting approximately 420,000 encounters per year. And if you know a hospital-based psychiatry program that actually has more clinical services and volume, I'm actually very curious because I actually don't know of any. There's some interesting trend that we are also seeing as well. Now we are about to go into some kind of balance between in-person psychiatry visits versus telepsychiatry visits, which we are gradually seeing the reduction and some plateauing we're beginning to see in relation to the balance between telepsychiatry and in-person psychiatry. And you see the similar trend also in child psychiatry as well. And you can see that it actually crossed between the child psychiatry in the middle of in the telepsychiatry and in-person psychiatry in the middle of COVID. And then now this is where we are. Now, with all these companies, mental health company, telepsychiatry startups that are now hitting our regions like Better Health, we don't know where this is going. And we'll see. I think this is a very dynamic time in relation to our overall ambulatory care strategy, which also leads into the importance of coordinating our overall 420,000 encounters. We cannot just keep expanding. We have to find a way to integrate and coordinate them. CPAP, everybody's curious. There isn't a whole lot of change in CPAP. Over the summer, we very much enjoyed relatively manageable volume, despite this interesting pop-up of the overall volume. Now, where does this, you see that red line is the overall CPAP visit volume, and the blue line is the last year's volume. And that area between the red line and the blue line represents the volume increase. Okay, so you can see that actually during the summer, there was a volume increase, but ultimately, that volume increase is largely in the adult side. So adult side, there has been some volume increase. On the children's side, however, it has remained maybe about the same. And that's a really unique story that happened in University of Rochester A lot of credit goes into our Division of Child and Adolescent Psychiatry team that have done very amazing job in terms of fielding off this tide of mental health tsunami that everybody used to call, in October 2021, American Academy of Pediatrics, American Academy of Child and Adolescent Psychiatry, and the Children's Hospital Association, they declared state of emergency for pediatric population for mental health because they saw this amazing increase in relation to emergency department visits around the country. But that didn't quite happen in Rochester. In fact, if you look at the overall trend, we might be one of the very few cities around the country that actually saw some reduction in child mental acute crisis visit compared to 2018 and 19 average to where we are. And our child psychiatry inpatient unit, remember how I told you that you were very lucky the census was low on the child side that allowed us to house geriatric patients into it? There's a reason behind that. Because our team in child psychiatry unit have done a wonderful job in terms of reducing the length of stay, taking care of more patients to the degree it actually created empty beds that we were able to use on an emergency basis. And along with the other things that we've done over the years, the Golisano Behavioral Health, the Pediatric Ambulatory Care Center, and the expansion and the diversification of mobile crisis team and the crisis line and the RSP program that reduced the length of stay. It's a lot of work. It also provides a blueprint, actually, to manage the acute crisis, psychiatric crisis issue, population health issue in relation to how we should approach adult as well. This is a slide that shows how much growth the mobile crisis team over the last few years have had. You can see that in the top is the pediatric visits that have gone up almost 100% over the last 2-3 years. Adult patient about 50%, and you can see the increase in volume. The amazing thing that doesn't really say is the side of right there, 1.92, okay, or 2.92. That's the number of the actual kids who were steered toward the CPAP. What I mean by that, through the MHT, what I mean by that is that they were able to divert almost 97% of the kids out from the CPAP. And think about how many visits we were able to avoid in our CPAP by being able to utilize mobile crisis team. Along with that is amazing work by our crisis call line, who handles now about 20,000 calls per year, that also provides better and more diversified service. So the overall strategy is relatively clear in relation to meeting the acute crisis needs of our community. Expansion is one, that's something that we have to do. Another thing that I can talk about forever is our school-based program that's been expanding into the city school district. And also diversification, expansion, diversification, and innovation. And in fact, we will do even better by creating a larger CPAP that has much, and also finally, on top of that, we'll aim to reduce 50% of our pediatric CPAP volume by 2024, having a Brighter Day Pediatric Behavioral Health Urgent Care Center that had a groundbreaking a couple of weeks ago. And these are the pictures. It's a wonderful example of partnership between academic institute and the community in being able to really come up with solutions. And this is another display. I guess the target day, is mid-spring of 2024. Thinking it was a little bit earlier, but maybe it was my wishful thinking a little bit. And because that would also allow us to have a more space for the adults and also reduce burden. Expansion idea will also happen in our inpatient psychiatry unit as well. Okay, believe it or not, we will expand the psychiatry unit by renovating 490-200 inpatient psychiatry over the next year. Now, it comes along with the idea of we really want to also, I actually bold-faced the word beautification, because 3,9,000 is really a unit that I really would like to see it improved in terms of appearance and more patient-friendly. And I was very excited to see that word being used in terms of that idea. And so over the next several months, 3,9,000, along with 490-200, will be renovated to provide more beds and more space and better and a beautified space for us. In total, approximately about $20 million will be invested in terms of our care. But, there is a challenge that comes after. Yeah, we are expanding. We also do the same thing in relation to diversification, mobile crisis, call lines, and etc. that we've done. What is our innovation? And that's something that we're going to have to tackle together. Okay. What is our quality improvement plan in relation to our inpatient psychiatry that will help us to integrate education as well as restraint issues, as well as other different issues? We really need to refocus on interdisciplinary teamwork, education and training that we are creating a task force around. And overall, making our CPAP and inpatient unit as a more of a learning environment. Particularly, the restraint and exclusion issue has been very divisive across the disciplines, particularly between the nurses and physicians, trainees. We'll be heading this directly by creating an Optim in relation to unit-based performance program with assistance of the Quality Institute over the next year. The central question is, again, it's about how do we integrate the education into our clinical environment, particularly in acute psychiatric care better? And that is really not an easy question, because over the years, we are so used to dealing with the crisis day after day. You're focusing on survival more than integration. And what we are hoping to do now is move from the survival crisis mode to more of a longitudinal view in relation to being a truly an academic department. We talked about, in my last year's grand round, the overall key strategies about how clinical service will utilize smart growth, research will do integration, education, innovation, and community application. And I was thinking along the line, maybe integration is key for all in relation to how we want to come across to become a team in relation to integrating all the missions, integrating all the disciplines as well. Now, somehow we've done that very well outside of our department. And here's a video. Okay. I don't know if it's... Steve? It begins with, yeah, that's it. It begins with our foundational belief that there is no health without mental health. We also believe the opposite as well. There is no mental health without physical health.
The Division of Collaborative Care and Wellness here in the Department of Psychiatry was founded with the specific aim to support the design and implementation of programs and services that are at the interface between psychiatry and general medicine. The biopsychosocial model emphasizes the importance of the psychological and social importance in the care of the patients.
I think the future of the program and of healthcare is innovation. We need to keep pushing the boundaries so that we can be able to meet our goals of delivering or improving the care of people with severe mental illness.
I'm showing this video as an example of how much we worked on integration outside of the department. It begins, when we talked about the boundary across specialties, we've done it to the nth degree. This is how much our Division of Collaborative Care and Wellness has grown through embedded psychiatry program, collaborative care programs, coaching programs, hospital-based programs. There's not a single department today at University of Rochester Medical Center that does not collaborate with us. In fact, we even have clinic in dental school. Medicine and psychiatry is in fact a national benchmark program that really demonstrates how we can integrate medicine and psychiatry within psychiatry department. And this division is now officially led by Telva and Marsha in our department. But to do a good job, of integrating ourselves, the ambulatory care programs still remain problematic in terms of integration and coordination. Some ambulatory care programs are thriving, while others, some aren't. Wait lists remain long. Referral process also remain problematic. And there are lots of issues, particularly integration of academic missions. Education and research into our clinical program remains an issue in our department. So that's what we really want to focus on, the boundary across the missions and boundary across the discipline. For example, recently we opened our UMHP program in Sully's Trail. It's a beautiful location, a beautiful facility that gears toward more of an insured population. Can we do something to integrate teaching and research around this beautiful facility? Okay. Now, one area that we have done unbelievably well is our research program. It actually started all the way from in last year. It was kind of ironic. At that time, one of my 5-year goals that was created at the end of FY22 was to hit $30 million mark in research funding. And ironically, we hit that mark before I proposed it, which is almost ironic. Will Pigeon, Ariel Schafter, Paul Geha, Anton, Steve Silverstein, and all these new grants poured in that led us to hit the $30 million mark. And that's not the end of it. In fact, in the last 4 weeks, we even have, besides the fact that the area and the Peter Wyman have made a cover of Rochester Medicine magazine, the NIH grant, the noticeable award we have received in the last 4 weeks are incredible. Tom O'Connor just got an ECHO grant renewal for $11 million. Peter Wyman and Tony Pisani have $7.3 million Wingman Connect study related to Air Force. Ben Chapman also has a very interesting study related to bilingualism's effect on the dementia risk, as well as Kim Van Olden's who not only has this R01 related to caregiver issue in Alzheimer's disease patient, but also potentially also have a K24 mentoring grant that I'm really excited about. And the Recovery Center of Excellence also got a renewal for 5 years, 16.7 million. We have more success this year, poised for more success this year than any time perhaps in history of our department. But the question also remains, can we integrate research into our clinical services? A wonderful example is our memory care program that's next to the AD care program that supports each other. We are also beginning to have integration in our young adults program. We have an EpiNet study based on early psychosis clinic. Lee Foundation is supporting a prodromal psychosis study, ProNet study that's about to be launched. We will integrate addiction psychiatry into research. We also have a medicine and psychiatry, a very example that's constantly re-examining its data, and many areas in collaborative care. We also need to find a way to integrate research and quality improvement into our acute and adult division, particularly in the inpatient unit in CPAP. And, you know, we also have had visits and reviews of different programs in our education. We had a very successful APA site visit for a postdoc fellowship program in psychology under the leadership of Jennifer West. Family and marriage therapy program is opening in November under the leadership of Jenny Spies. And then, you know, I was looking at her email, and I was really touched by this idea of really being eager to show off our talented educators and supervisors and incredible curriculum and clinical teaching that we offer in our program for family therapy. I want to have the same spirit of confidence across our teaching program. And we do amazing job of supporting people outside of department, outside of our program. Coaching program now supports every major residency programs at URMC. I think something like it's counting 13 residency programs. But we are right now in the middle of psychiatry residency training program based on the results of 2023 ACGME resident survey. And there are concerns that are raised by overall quality of education and well-being of our residents. And it also follows another special review in 2019. At that time, primarily focused on CPAP, and that does seem to have improved, but we're gonna have to see. There are several areas of concern that are raised, and we're gonna be meeting them one by one, comprehensively over the next year through a special review task force that we created to meet the recommendations of the special review. There is a specific issue related to mentoring of the faculty and development of faculty. So we'll develop a task force on faculty development. And we'll also, again, I think really develop this QI project with the residency program in relation to Optim, and more details to come. Our identity as a department is an academic clinical department. If you look at our mission statement, across the board, there is this emphasis, and there is mention of teachers, there is mention of also education excellence in our vision, and our value also reflects our education as well. But the reason that I highlighted and redlined it is that for somehow in the middle of our efforts to expand our program, we have created education gaps that we really need to bridge. Now, quick thing about why this is important. I'm gonna just zoom through this. The community that I always have wanted as our department is this fellowship of sharing a common values and interests and goals. Okay? Because the community that we serve is really large. We have to work as a community team in order to serve our community. Is it Rochester? Is it Monroe County, Greater Monroe County? And is it now the whole 8 hospital system we are looking at in relation to trying to cover them? We serve these areas, this broad area that all the way from Canadian border to Pennsylvania border, not just simply by providing clinical care to different places and having access to them. We do it from our medical center, from our department, so that they can serve the larger population. We also have to innovate through research. And that is the burden and responsibility of being an academic clinical department. And that's something that we're going to have to embrace and think along the line in relation to really addressing all 3 missions in all clinical settings. And the other thing is our community nowadays expects more from our department. When you look at the dictionary in terms of definition of psychiatry, it says branch of medicine that's concerned with study, diagnosis, and treatment of mental illness. That's not our definition of psychiatry. For whatever the reason, whether we have somehow took on that journey, we have medicine in psychiatry, we have employee-based health programs, dementia care is also unusual for psychiatry, WISH program, HEAL programs, and etc. That is really touching the boundaries of psychiatry. In fact, there was a visit by one of the trustees to our Department of Psychiatry. Nowadays, we field a lot of visitors simply because of the importance of mental health. Recently, President Mangelsdorf also visited our department. And the comment from this trustee was that, what is it that you don't do? And that comes as a sort of question and also somehow something to really chew upon. Because a good example is just looking at our CPAP. Why do patients come to CPAP? Well, the usual reason is exacerbation of psychiatric symptoms and acute and threatening symptoms in their life. But in reality, they come because of poverty, drugs, homelessness, crimes, violence, relationship issues, unemployment. Many of them, almost all of them, is sent back to the community with the same issues. Are they really the role of psychiatry to address all these social determinants of health that we are facing in our work areas? It's an open question. I actually don't know the answer. All I know is that we cannot turn them away. We have to serve whoever is in front of us to the best of our ability. Let me give you an interesting example of a recent development in our department, gun violence, for example. It's a public health crisis, but is it psychiatrists? Is it a psychiatric crisis? As you know, it's now, it's the #1 cause of death among children. And it's also a local issue. 183, there are a lot of gun violence victims that comes to University of Rochester Medical Center. And also, there is a disparity in relation to how African-American teenagers face disproportionate risk as well. Mass shootings are on the rise. We know that Buffalo had a terrible, terrible mass shooting last year, as well as in Texas. Here's a trend is a graph that I used last year to argue for gun violence program, along with Michael and Jennifer West and Corey Nichols. Now, when we were arguing, we didn't realize we'll be taking on this program into psychiatry, but that's the expectation now. Social determinants of health, all these issues relate to society. Okay. Medical center, time to time, quite often, will come to us to provide leadership. That makes our job really challenging, trying to balance clinical care that we need to provide for all our community, need to provide good education, research, and the expectation from the community. That then makes it very challenging. But ultimately, that's why we need to integrate more and work more as a team. There is a tremendous complexity that I deal with on a daily basis related to administrative and financial complexity, as well as how we balance our missions and also expectation from the community and the medical center. Recently, our department was also lead overall strategy for the pain service as well. Okay. So this is really starting to touch borders. And it was interesting. I noticed I was the only clinical chair invited to recent retreat related to Eastman Performing Arts Medicine. There is a discussion related to sleep. In other words, psychiatry, we have essentially made a permeable boundary over the last several years to the degree now we are very much part of not only medical center, but we are also asked to lead as well. The question is, that permeable boundary, can we apply to ourselves to integrate our missions, integrate our disciplines? So, overall, the recent fire in 390-200 really reminded us of the importance of our department in our community. Okay. If we are paralyzed, our entire mental health system in our greater Rochester area gets paralyzed. And during that crisis, we worked so hard to get everything on board by demonstrating unbelievable teamwork and our values: complementarity, communication, collaboration, competence, and compassion. We serve our community by being an academic and clinical department. And our department today is marked by continued expansion of services and research success. But we have gaps in our missions, especially in education, that we need to address. We really have to ask ourselves, somewhere along our rapid expansion have led to gaps across our missions and disciplines and created a schism among them. And while we did that, somehow we have ended up creating a sense of, eroded sense of community in the Department of Psychiatry. And we have to work together to integrate our academic missions, especially education mission nowadays, in our clinical service. It is a reminder that our values are not just important when we are facing crisis. We've done wonderful things over the years during the time of crisis. But as we are now heading toward post-COVID, hopefully, although I did hear a couple of our faculty just came down with COVID, that we need to demonstrate our values in the time of peace, in the time when we are not in crisis as well. So, thank you.
Thank you so much, Dr. Lee. Before we open for questions, just a reminder, I see many of you with your phones out capturing the QR code. Please do complete the evaluation for today's session and for all subsequent sessions. Your feedback is really valuable. If you're attending online, there is a link in the chat for that same evaluation. These are time limited, and so the link does expire as we get closer to the next Grand Round session, so please do complete that. Before we head out for today, are there questions either from the Class of 62 audience or from the audience online for Dr. Lee? I shouldn't have said something about the evaluation first. Now everybody's doing the evaluation. Well, let me just say thank you very much to Dr. Lee for your thoughtful and insightful presentation today about our department and its expansion, but clearly with the missions focused on integration, teamwork, and innovation, with a special focus on education and interprofessionalism. Those values are near and dear to my heart, and I'm excited to see where we go next. So thank you very much, and we'll see you all next week.
Great. Thank you. Thank you, everybody.